Thanks for joining us today. And we're really excited to speak about patient empowerment, putting patients at the center of healthcare AI, more than data sources, as decision makers. So here we're covering the full spectrum. We have research, product, and policy. So just want to briefly introduce the three. We have Adrien Coulet. So your research combines data and expert domain knowledge in LLM and guiding clinical decision-making in digital health. And you're Inria, but you're also with HeKA, which is a joint lab.
Yes, so it's a joint lab with first Inria, but also Inserm and the University of Paris-Cité.
Okay, fantastic. We'll find out more later. And Nacim Rahal, so a Vice President of Data and AI at Doctolib. You're building and scaling real-world AI products for patients and practitioners at Doctolib. So we'll be finding out more. And Dr. Derya, so you're the inaugural lead of the OECD expert group on AI for health, and you'll be giving us a policy perspective on AI in healthcare and global health equity. So looking forward for your insights. So let's kick it off with product. So Nacim, in what specific ways are your AI tools empowering patients to improve access to healthcare and working with practitioners closer together?
Thanks. I think first and foremost, enabling access to care has been in Doctolib's DNA from the very beginning. And even without AI, our solutions and system and what we provide is something that can actually shorten the delay to access care by several days. So it's what we've been seeing so far, but it's been mostly by being the place where 90 million patients across Europe go to book their doctor's appointment. And of course, what happens if you're not super comfortable going online to make these type of things? So that's actually where AI can help and bridge some of that gap. Typically, one of the products that is live today in Germany and that we're just releasing in France is a phone assistant that is deployed in medical practices that can help patients just call and book their doctor's appointment, modify them, ask questions about their health, be able to renew prescriptions, of course with the validation of the practitioners. But this is something that is going to enable a whole spectrum of the population to have better access to care with AI being able, and AI agents specifically, being able to power these type of experiences. So that's one very direct impact. But there are also less direct impacts, which are I would say the benefits and the consequences of solutions that we provide directly to practitioners to enable them not to have to care about administrative tasks and being able to reduce the time they spend on time that is not medical care, basically. And what we see is that many of the solutions we provide actually amount to saving every week 5 hours and 30 minutes to general practitioners and pediatricians by saving administrative time and making more space for medical time, which of course is going to have effects on improving access to care for patients by having more offer. And that's even without considering the impact of AI and typically the consultation assistant, which is an AI scribe that we provide to practitioners and enable to take notes automatically during consultation. This removes mental load on practitioners, but also save them about a third of the consultation time that they spend typing on keyboards and looking at their screens. So this is also going to have an indirect effect on access to care. And maybe finally, and this is super fresh news because it's something that we just did yesterday. We've signed a common joint lab between Doctolib and Inria to work on some of the most complex topics that we have to crack and that we want to address together. Some of them are going to be directly impacting access to care, like optimizing patient journeys by trying to use AI to improve patient outcomes given the healthcare system constraints. But there's even much more that we can be doing together with Inria and specifically with Adrien.
Thank you. I can't wait to hear more about this. So bouncing off the role of Inria, what research standards and safety protocols are most critical when developing AI systems for clinical decision making? And how do you address bias, for example, as well?
Yes, so very good question. Yes, thank you. So we are of course, we are doing a lot of evaluation. So when we want to show like one approach is better than the previous one from the state of the art, we have to prove like with different metrics that it's better. But indeed, there is a set of metrics which are focused on fairness. And for instance, it check if your, let's say, clinical decision support system has reached the same performances for every group. So one very important question is to identify sensitive groups in your population. Do you have chances to have a particular group for which the performance could be detrimental? And then make sure that for this group the performance are at least as good as for the others. And so that's one way of evaluating fairness. But something I think interesting is if we do a step backwards, then we can think like something which impact a lot the fairness in the decision is basically how much data you have for the patient. And of course, what we have and what we are working on mainly so far is hospital data. So in hospital, you have a lot of data, and that's very good to make it detailed, fine-grained data. So it's very good to make like clinical evaluation of risk, clinical prediction, and then support decision. But then there is plenty of data from the patient that we don't have, like what has been collected during primary care, for instance. There is many, for chronic disease, for instance, there is many information that is, for instance, available in the electronic health records of the primary physicians, which we don't have access because of this siloed structuration of the healthcare data. At least in France, I think it's the same in many places. And yes, and one of the goals of the collaboration between Doctolib and Inria is to focus also our interest on primary care data, outpatient data, and try to develop system where we can combine AI systems where we take into in account rich hospital data and primary care data.
Okay, thank you. So just building on that, we'd like to ask Dr. Derya, so how can we make sure that AI-driven healthcare innovation actually benefit diverse populations across different healthcare systems and economic contexts?
Okay, so this is a great question, but obviously I'm not going to be answering it in detail in the 2 or 3 minutes that is given to me. It's impossible. But what is really important is to reimagine, rethink tech. If we remain tech-oriented, then it's not going to be as successful as we would like it to be, ideally. Let me explain that. I'm working for the World Bank, which means that I'm interacting with the governments of countries around the world. And we do see that different countries are facing different challenges. But the one main thing that we see again and again is that the technology itself is not a problem. What most of the times, and we are here at the Adopt.AI Summit, so the question is how can we make people adopt technology? It's actually, when you think about it, it's not that complicated. You have to give them something that's easy to use, that's accessible, and accessible means that they have resources and the access to actually have the tools and use them. And then it has to be something that they need and that they demand, right? You cannot impose things on people to use, so that they need to have a need for that. And we have seen, for example, an example of a country that wanted to implement an application to collect data from rural areas where they didn't have clinicians, they only had the so-called community health workers. The application was developed by the state, so actually very impressive. But it didn't work, it failed. Why did it fail? It wasn't the technology. What made it fail was because the application obviously ran on a smartphone, and the community health workers who needed to use this app to collect the data couldn't, because guess what? They didn't have smartphones. And they were being paid only the equivalent of $20 per month, which wouldn't allow them to get a smartphone, let alone then to pay for data packages every day. So such things in resources, accessibility, infrastructure are the points that make the adoption of AI fail on a global scale when we think about it. And there is a second thing. This is an example from a developing country, but when we think about the context in France and Europe, then there is a staggering statistic, which is that 45% of Europeans do not have the basic digital skills. So now we want to digitalize healthcare. how are we going to make that if 45% of the population do not have the digital skills? In France, it's better, we have to accept that, but it's still 15% of the population that do not have the digital literacy that is needed. So obviously, this is one of the most important points that needs to be worked on. And I could go on and on about this one, but maybe I will conclude with one thing. When we're talking about equity and accessibility of technology, then there is a film that you all absolutely have to watch if you haven't yet. It's called I, Daniel Blake. I highly recommend it. And well,
thank you. So just building on that about some disconnects. There's also a bit of a disconnect in the fact that apparently doctors disagree 60% of the time with each other, right? So how do you build together, maybe how do you build these tools when there's difficulty in evaluating the criteria of a successful AI tool?
So obviously that's a big challenge, and I guess I'm going to take the very specific example of Doctolib Parents, which is a solution that features an AI chat for parents where they can ask questions about how to best care for their children and get authoritative, validated answers. And of course, what we want to do is to make sure that the system is safe, and we want to evaluate it. And one way to evaluate it is to do it against some sort of reference. And we're building that reference with physicians, so we take experts in pediatry. We also provide them with specific guidelines that they can use to evaluate clinical cases. And it's true that what we observe is that they are basically in agreement. So we have multiple experts reviewing the same case, and they're in agreement roughly 40% of the time. In all of the other cases, there is at least one disagreeing with others, and we have about 10% of cases where they all come to different conclusions. So before even building an AI system that is able to address these cases, we need to make sure that we actually nail things right when it comes to what are the guidelines, what are the type of things that we expect the system to do. There are many ways to address that. In some cases, it's about clarifying guidelines, so they are super explicit and there's no place for ambiguity. In other cases, there are tricks about, of course, having an odd numbers of experts so that you can take majority votes, and sometimes forcing consensus as well. But it's something that was actually surprising to us when we saw the extent of the noise that we see in some of the decisions. But I think overall evaluation is a hard job, and I was discussing with one of the engineers working on that system yesterday, and he was telling me that roughly 90% of the code base is about evaluation, and 10% about the product itself, which is what people will eventually experience. It's already in production. We have 7,000 people using it in beta mode, but it's not fully released yet. But that piece is just 10% of the overall code base, which is one way to evaluate the whole work that has to be done. So evaluation is hard. There's no silver bullet. It's just a lot of hard work to make it work. And in some cases, we know that we're nearing or just crossing the boundary of the state of the art, and that's also one of the topics that we want to be working jointly with Inria to better design systems that are AI systems that are safe and that are going to maximize the outcomes for the patient. So it's a hard job, but we're taking it super seriously.
Thank you.
If I can add something from the technical point of view of basically the mechanism you were explaining, I'm really believing in reasoning capabilities, and so you get explanation and use of why one answer or what suggestion is done, and of sourcing this argument. So, okay, this argument has been made, but it's coming from this exam, these results. So it's one part of your reasoning. Or it's coming from these guidelines, which is coming from a college of experts that published it. So yes, so I think mixing reasoning and sourcing is one of the key from the technical point of view to reach these goals. Yeah.
Okay, well, just building on this one, there's also a bit of a disconnect in healthcare data, which is very siloed, as we've heard throughout the conference, especially hospital systems, practitioner records, limited integration even in France with the National Registry of Data. So how does this fragmentation impact the ability to create longitudinal patient profiles?
So yes, so that's a topic I evocated just a bit earlier. But yes, it's a true limitation. One, it would be great to have both. It's true it's a source of unfairness, of inequality, as okay, then my physician uses this great AI system, but it's my first visit in this hospital, and maybe I will not have the same quality of prediction or of evaluation of risk or of help as if I was followed by this hospital and it was my second or my third visit, because I don't have the same follow-up of my data, and that's unfair. Why do the previous hospital where I went to don't share the data together, or why my primary care physician don't share the data he has with the others, so I can take the advantage of these very nice tools.
And so you're talking about sharing data. So what do we know about patients' willingness to share their data? Like, does it vary between populations and different conditions? How does that work?
Yes.
Okay.
So there is few studies which are of debatable quality, but mainly, let's say 70% of the people in the general population agree to share their medical data for research, and when you switch to sick people, it's rise to 90%. So, and you can guess, like, if it's people with even like conditions that are not well known, which are seeking for treatment, it's probably even higher than 90%. So indeed, when we are talking about healthcare data, it's only people who came to the healthcare system because they are sick. So indeed, it's already 90%. So I think there is, at least the European Union in this area is trying to push with this European health data space with an idea of forcing everyone who deal with healthcare data to be able to provide it and to share it according a certain amount of funding, but they will need in 2030 to be able to provide the data they collected for someone. So I think that would be a great goal. So you can imagine, like, every individual can access his own data, either it was collected from one hospital, one system that is used by his primary care physician, and once this is centralized, like, take advantage of his all follow-up data. Yeah.
Okay, thank you. I'd like to hear a policy perspective on this topic now, because do we actually have governance models that let patients control their data while enabling research? It'd be great to hear that.
Yes, we do have governance models, and no, they are not applicable to all contexts. So it's a tricky issue. So there are different factors on which this is dependent of. Those questions are: how big is the country? Is the country centralized or decentralized? And the last question is how high is the public trust? In a country such as, for example, Finland, where we have high levels of public trust, and this country is a relatively small country, there are excellent models that work provenly very well, such as their model that's called FinData, you can Google it, where they have basically a one-stop shop where all health data that might come from different institutions and different organizations are being basically not collected but managed. So whether I'm a business owner, I want to make an innovation, or I'm a researcher, or whatever it is that I'm doing, and I need patient data or health data, I can go to FinData and I can tell them, this is my research project or this is my business project and I need this data. And then they run it through an ethical board and see if they're going to allow it or not. And if they allow it, then they basically have the access to different organizations. So they collect the data from them, they prepare data sets, and they hand you the data set. So that you don't have to go to 10 different organizations and get data permits to be able to use the data and do your research or innovation. So this is obviously a very innovative, good type of data governance that can be used. But on the other hand, if you think about context in which you have a country of several hundreds of millions, or if you have a country that's very decentralized in governance, or you have a country where the trust in government institutions not particularly high, so people are not going to be happy with their data being organized by a central organization and then handed out, that turns out to be more difficult, more tricky. So those are the factors that we have to keep in mind. Yes, there are governance models, but they're going to be different in different contexts.
Thank you. And just building on that quickly, is there a balance between innovation and ensuring the safety and actually innovating faster?
I'm really happy that you asked that, because this is something that's coming up and up. I want to ask the audience, how many of you have heard something in the lines of innovation and regulation are contradictory? They don't go hand in that. There's a tension between them. Can I see the hands?
There's a few hands.
Okay, so many of you have heard that, but this is a myth, and we need to do some myth busting here, I think, because actually, and I want you to believe in me in that, trust me in that, regulation is an ethical innovator's best friend. All right? Because regulation, we have regulation for everything. It ensures that we are safe. It ensures things such as when I go and buy water from the supermarket that there are no heavy metals in that water. It ensures when I go and buy food that there are no bacteria in that, I don't know, salmonella that's going to make me sick, right? And it's exactly the same thing in healthcare, actually. So if I were to come to you and tell you, here's a new therapeutic or a drug, I developed this, it's good, take it. You wouldn't just take it like that without asking me, is there evidence, is it safe, is it effective, right? But obviously we cannot do it always one by one. So there needs to be an independent third actor that asks those questions for us and makes sure that things are safe, first and foremost, and then effective. And this is what regulations are doing, basically. But there is a discourse that basically wants us to believe that regulations are bans. They are not at all. They're just making sure that everyone is playing fair and everyone's safety and basically best interest is being ensured. So I would say innovation and regulation, they're actually best friends.
And also two other conflicting issues perhaps, enabling care and supporting prevention. How are you designing products that effectively serve both these goals?
It's a very good question, and I think one of the biggest opportunities for AI to help patients take care more of themselves and be in charge of their own health it's a huge opportunity. So prevention, continuous care are opportunities that AI will unlock. However, it also comes with risks that are associated to that, and I think in France it's 42% of the population that has one day taken a suboptimal health decision based on online information, and it actually gets to 73% when this information comes from social networks. So there is definitely some balance to strike between, unlocking continuous and preventive care through AI, but also making sure that the information that is provided to patients is safe. One way to address it is to work directly with the most authoritative sources in the domain. So that's what we're doing at Doctolib when it comes to childcare. We're working with the French institutions and societies on pediatry to get the relevant local information. As we work in multiple European countries, we would do that as well in Germany, in Italy, in the Netherlands. But that's one way to make sure that we do have all of the benefits of that opportunity to unlock preventive and continuous care with limiting the risk of having information that is not accurate getting into the hands of patients and leading to suboptimal outcomes sometimes.
Thank you. And before we wrap up, would you like to share some of the topics that you'll be working on in the joint collaboration? Is that allowed?
Yeah, of course. Like one of the topics is to keep on that thread is going to be able to make sure that AI systems can best leverage medical information so that we can provide good advice, outcomes, recommendations. Others are going, and we actually have a PhD thesis starting on that, to quantify the uncertainty of LLMs when they are providing recommendations to patients. This is something that is super important. There are going to be other things that are already touched upon. We do have a thesis starting on optimizing patient journeys. So these are all of the topics that we want to cover. And one of the common themes throughout all of this is going to be evaluation and making sure that everything is done safely. Don't know if you want to add anything about it.
Yes, and maybe we said a lot. We talked a lot about sharing data, extend the personal data sharing. but there is also things that we have in common is we are interested in sharing what we named medical knowledge. So in whatever format it is, in text, in knowledge graph, in like rules, there is many online. It's great input data for the LLMs, but again, not everyone has the same access to all this medical knowledge. So that's something also we want to work on, make sure like the system we develop have a huge access to this medical knowledge.
Thank you, and I'm so pleased we have a lot of experts working on this project. Thank you all so much for your input. It was really fabulous. Let's give them a round of applause.